Hello everyone, hope everybody's doing great. Let me tell you a bit about myself. I am Amanda Felix. My initial nursing schooling was started at Sir Arthur Lewis Community College in Castries, St. Lucia, and after being successful with the nursing council exams, went on to work at Victoria Hospital for a period of 10 years as a registered nurse. I am currently a registered nurse in Miami, Florida, after gaining success with the NCLEX in 2002. I obtained a Bachelor of Science nursing degree from Florida International University and soon went on to pursue graduate studies. I am currently enrolled in the Doctor of Nursing Practice program with a focus in adult gerontology and acute care nursing at Barry University. I have been employed as a critical care nurse for the past 16 years in the adult intensive care unit at Aventura Hospital and Medical Center in Aventura, Florida. Today, I will be disseminating the research I have assembled under the caption Improving Delirium Detection in Adult Intensive Care Units. This is a very interesting topic, and I do not think it gets talked about enough in the ICU. I have viewed the misery and misfortunes with acutely ill patients experiencing delirium in the Adult Intensive Care Unit, and I am excited to share the research about this topic with my colleagues to improve health outcomes in the Adult Intensive Care Unit. Delirium is an acute onset of mental status change that results in the patient becoming inattentive, experiencing disturbances in consciousness, change in cognition, and perceptual disturbance. It develops over hours to days and fluctuates over time. Delirium prevention would ensure that patients have decreased ICU stays, decreased hospital stays, decreased time on the ventilator, and overall decreased morbidity, mortality, cognitive defects, and healthcare costs. Today's topic will convey lots of information, but I implore you to stop and think about why you are working in the adult intensive care unit. Hopefully, it is to help improve patient health outcomes with all available resources provided, especially evidence-based practice guidelines, current research, and ICU standards of practice. Now let's review the objectives. At the end of this project dissemination, viewers will be able to define delirium and discuss the types, discuss its background and purpose as it pertains to patients in the ICU setting, identify the target audience and highlight why they are important, understand the educational plan proposed for this project and highlight its significance, recognize the significance of delirium assessment, prevention, and management to healthcare, distinguish the significance and potential impact on healthcare practice, healthcare outcomes, healthcare delivery, and healthcare policy, comprehend the projected outcomes of the implemented project, and discuss the significance of the project to the 8 DNP essentials. What about the main purpose for this project? The main purpose for this project is to outline nursing strategies to adult ICU nurses for the assessment, prevention, and management of delirium as outlined by the Society of Critical Care Medicine Critical Care Practice Guidelines. Additionally, to teach ICU nurses how to correctly use the RASS, the Richmond Agitation and Sedation Scale, and the Confusion Assessment Method for the Intensive Care Unit, the CAM ICU. What is the problem in the adult intensive care unit with delirium? Among ICU patients, delirium is linked with a myriad of complications and adverse outcomes. Some of them include impaired ventilator weaning resulting in additional days. More patients remove their lines and drains and tubes when they become delirious. Additionally, when patients are delirious, they require sedation, which results in ICU-acquired muscle weakness as a result of immobility. This increases their morbidity and mortality, and an increase in cognitive decline, which is comparable to Alzheimer's, the effects of which persist well after discharge. By extension, increased healthcare costs and increased discharge to a skilled nursing facility. Let's talk a little bit about the origin of the term delirium. Delirium is a Latin term. The Webster Dictionary defined delirium as an acute mental disturbance characterized by confused thinking and disrupted attention, usually accompanied by disordered speech and hallucinations. The term delirium has been in existence for greater than 2,000 years. Hippocrates, during the 18th century, denotes delirium as fremitus, meaning frenzy, and lethargus, meaning lethargy. Celsus first used the term in medicine during the AD to denote agitation or somnolence following head trauma and fever, and it was viewed as a sign of impending doom. Other terms used today for delirium: acute confusional state, acute brain syndrome, and ICU psychosis, and a litany of others. How can you tell if a patient is delirious? Here are the characteristics of a delirious patient. 1. This patient experiences a change in their baseline mental status. It's an acute change or sudden change. 2. It develops usually hours to days. 3. It fluctuates throughout the day or night. 4. There is a disturbance in cognition, which is their memory, their orientation, and their perception. And 5, this patient experiences decreased attention. How can you differentiate the types of delirium? There are 3 types of delirium, denoted by varying degrees of psychomotor activity. Hyperactive, which is characterized by restlessness, agitation, and emotional lability. It is most easily recognized. Hypoactive, it is the most common subtype in critically ill adult patients, accounting for almost 60% of the prevalence of delirium. It is associated with the worst prognosis and is characterized by slowing psychomotor, demonstrated by a calm appearance, inattention, decreased mobility, flat affect, withdrawal, apathy, lethargy, and decreased responsiveness. The third type is mixed delirium. It is characterized by periods of hypoactivity, fluctuating between periods of hyperactivity. So a combination of the hyperactive type and the hypoactive type. How could we denote which patients will experience delirium? There are several mnemonics that have been created. One such as the think mnemonic, THINK, T for toxic situations like overdose, alcoholism, sudden street drugs and medication, congestive heart failure, patients who are in shock, hypovolemic shock, septic shock, patients who are dehydrated, deliriogenic medications, new organ failure. H for hypoxemia, patients who have low levels of oxygen in their blood may become delirious. I for infection and sepsis, patients who have certain infections, it causes them to be delirious. Immobilization, no movement, they're just lying in one position. Non-pharmacologic interventions employed. For example, assisting the patients with donning on their glasses, putting in their hearing aids, putting on music, the news, the television, the newspaper, allowing the light up, the shades up in the daytime, and in the nighttime allowing the shades down, and noise control. K for electric. Here is another mnemonic to help us remember risk factors and causes of delirium. ICU deliriums. I for iatrogenic exposure. So some medications and antibiotics may give patients adverse drug reactions. They may not have the untoward effect that it was intended for, and because of that, they can become delirious. C for cognitive impairment. Some patients who are demented or mentally challenged or delayed, because they're not able to interact with the caregiver or interact socially, they may become delirious. Use of restraints and catheters. For you, some patients, because of overdose, because of alcoholism, because of drugs, they may need restraints, they may need catheters, they may need lines and tubes. And because of that, they may not want to participate in care. So they would not like the restraints and the catheter, so they can become delirious. Other medications, overdose, certain drugs, anesthesia, post-anesthesia, some patients can become delirious. They can have acute changes in their baseline mental status. Eye and ear implants. So patients who wear glasses, have hearing aids, we have to assist them with donning on the glasses and inserting the hearing aids, because they may not be able to interact or communicate effectively with the healthcare giver if they don't have those eyeglasses on or the hearing aids. And lab abnormalities, so patients who have low potassium levels, low magnesium levels, low calcium levels can experience delirium, because with low potassium you can have arrhythmias, low magnesium you can have cramping, and low calcium you can have cramping also. Infections, certain infections can have patients experiencing delirium because of high fevers. Respiratory, patients who are hypoxemic or hypercabic, patients who have low levels of oxygen in their blood or high levels of CO2, like the COPDs, those patients may become delirious. Intracranial perfusion, patients who are hypertensive, who experiencing hypertensive crises, so those patients can become delirious. Urinary and fecal retention, so patients who are constipated or patients who are not able to void may become delirious from the overextension of their bladder or their rectum. Patients who have an acute MI, M for myocardial infarction, so patients who have an acute MI, they may become delirious because they don't know what's happening to them, and they may feel like they will die. Who have not slept in a number of days. Now let's talk about some numbers. Despite its high prevalence, delirium remains unrecognized by many ICU professionals. Several studies have demonstrated that ICU staff in general and even physicians are not keen at identifying delirium. Often, mental status changes associated with delirium are misattributed to dementia, depression, or just unexpected occurrence in the critically ill patient. 80% of patients in the ICU experience delirium, 60 to 80% of mechanically vented patients, up to 50% of those that are non-vented, 70% of those coming into the ICU already experience delirium, and 75% of those patients are missed without routine screening. Annually, 1.7 million people survive the ICU annually. How many of those are functional? 50 to 70% are cognitively impaired. 60 to 80% are functionally impaired. What about the economic impact? 40% increase in healthcare associated costs. The national burden is 38 to 150 billion annually in associated costs. There is an increase in the length of stay in the ICU, in the hospital, on the ventilator with increased tracheostomies, long-term neuropsychological deficits, functional deficits, and disability and mortality. Delirium, what it is and what it is not. With delirium and dementia, what is the same with them is impaired memory. Those two syndromes, those two conditions have impaired memory. What is different with them is their onset, their pattern, and duration. With delirium, the onset is acute. The duration is hours to days. The pattern is fluctuating. Unlike dementia, the onset is gradual. The pattern is progressive, and the duration is months to years. What fluctuates for the two of them is their orientation and attention. So a patient who has delirium and dementia may have fluctuation with their orientation and their attention. So at times they may be fully oriented and attentive, and at times they may not be oriented and not be attentive. Every patient who enters the intensive care unit is at risk for experiencing delirium. They're vulnerable, and remember, delirium is dangerous. There are several entities who are committed to ensuring that critically ill and injured patients receive the highest quality of care. Guidelines have been developed in an effort to help ensure consistent evidence-based care for critically ill patients using the most up-to-date and relevant knowledge available. One such organization is the Society of Critical Care Medicine. The Society of Critical Care Medicine is a non-profit organization which thrives on creating guidelines to ensure critically ill and injured patients receive the highest quality of care. It was established in 1970. It's international, educational, and a scientific society based in the United States. It functions to support research, education, and advocates for issues related to critical care. Any professional who works in the ICU can be part of the SCCM. And any patient who is currently in the ICU or who has been in the ICU can get valuable information from the Society of Critical Care Medicine website. Another entity is the CIBS Center, the Critical Illness, Brain Dysfunction, and Survivorship Center. It has over 2 decades of research regarding delirium to combat the debilitating effects, to prevent the increase in deaths, prolong ICU and hospital stays, significant higher medical costs, prolonged neurocognitive disability after discharge. Wes Ely and his colleagues, including Pratil Panharipande, have identified delirium as one of the most critical problems facing ICU patients. Several studies have been carried out at the CIBS Center regarding cognitive scores following delirium. Alzheimer's has a score of 70, dementia 80, and mild cognitive impairment 84. After 3 months, 105 patients were evaluated, and 28% revealed scores of 80 to 89, dementia and mild cognitive impairment. 106 patients had scores of 28% of those patients had scores of 70 to 79, dementia, borderline, and Alzheimer's. 90 patients evaluated after 3 months, 24% of those patients had Alzheimer's symptoms. After 1 year eval, 68 patients, 21% had Alzheimer's symptoms. 85 patients were evaluated, 26% had dementia symptoms, and 103 patients, 32% had 80 to 89 mild cognitive impairment. Let's talk about the assessment tools for delirium assessment. We have the CAM, which was created by Sharon Inouye in 1988 for use outside of the ICU. Then we have the CAM ICU, which was created by Wes Ely in 2001 for use in the ICU for mechanically vented patients, and the RAS created by Sessler and the other researchers for use with the CAM ICU assessment. There are greater than 45 instruments that have been created to measure consciousness in the ICU setting. Only 3 have shown a high degree of reliability and validity to detect delirium in the adult ICU patients. We have the Richmond Agitation and Sedation Scale, the RAS scale, the ICU delirium screening checklist, and the confusion assessment method for the intensive care unit. We will only talk about today the RAS and the CAM ICU. Critical care nurses play an important role in the implementation of interventions for the prevention and management of ICU delirium. A varied number of studies have been performed to establish their knowledge, perception, and practice habits regarding delirium for the ICU nurse. The results are alarming. There is limited knowledge by the ICU nurse on delirium. There are sparse, non-structured assessments and sporadic adherence to evidence-based practice guidelines. The first guidelines created for the management of pain, agitation, and delirium in adult ICU patients were done in 2002. These guidelines provided a roadmap for developing integrated evidence-based and patient-centered protocols for preventing and treating pain, agitation, and delirium in critically ill patients. For assessment, the gold standard in 2002 to diagnose delirium was the clinical history and examination, as guided by the DSMV 4th edition. The work was begun by Hatt and colleagues to find a tool to detect delirium. 20 patients each were used in 2 investigations, but it was limited because not the severely ill patients who were often cared for in the ICU were used. For prevention, sleep promotion, music therapy, and relaxation was used. For treatment, typical antipsychotics like chlorpromazine and Haldol were the most commonly used to treat delirium. Chlorpromazine was not recommended due to its EPS symptoms, and Haldol due to its QT prolongation. Following the 2002 guidelines, the 2013 Pain, Agitation, and Delirium guidelines were created. Those guidelines were created to define best practices for optimizing the management of pain, agitation, and delirium in adult ICU patients. The objective was that the 2013 Pain, Agitation, and Delirium guidelines were to update the 2002 guidelines for the use of sedatives and analgesia. Those received and offered grades of recommendation which focus on quality of evidence. A would be a high quality of evidence, B moderate, and C low. For strength of recommendation, 1 would be strong, 2 would be weak, plus would be in favor of, and negative would be against. The recommendation is that patients be assessed for delirium Q-shift using a validated screening tool. The 2 tools that have been recommended was the CAM ICU or the ICU delirium screening checklist. Both tools have a high inter-rater reliability and have been tested by multidisciplinary ICU clinicians. The recommendation is also that patients be sedated at light sedation, -2 to +1. -2 entails that the patient briefly awakens to voice with sustained eye opening and contact for less than 10 seconds. And +1, the patient is anxious, apprehensive movements, but they're not aggressive. For prevention, the recommendation is that the patient's pain be treated as needed first before sedation. If there is a reason for pain, treat the pain first. Reorient the patient, familiarize the patient to the surroundings. Use sensory aids, hearing aids and glasses, reduce noise, encourage early mobility, use benzodiazepines only for alcohol withdrawal or for benzo withdrawal. Avoid antipsychotics due to the increased risk of QTC prolongation, and use the ABCDEF bundle. For treatment, identify the risk factors for delirium: hypertension, alcohol abuse, high severity of illness, coma, benzodiazepine administration. Mobilize patients early, promote sleep, control noise, cluster patients' activity, decrease nocturnal stimuli, restart baseline psychiatric medication if needed. Also encourage cognitive stimulating activities. The 2013 guidelines do not recommend Haldol or atypical antipsychotics to prevent delirium, as they cause torsades de pointes, hypotension, and bradycardia. There is no FDA-approved drug for the treatment of delirium. The 2018 Pain, Agitation, and Delirium guidelines included the addition of 2 inextricably related clinical care topics: immobility and sleep. For assessment, it's the same as the 2013 guidelines, which included assessment Q-shift and PRN for delirium using a validated screening tool, the CAM ICU or the ICU delirium screening checklist. For prevention, multi-component non-pharmacological interventions and the use of the ABCDEF bundle. For treatment, the recommendation is that propofol could be used or Prexides over benzodiazepines for sedation in critically ill mechanically vented adults. Identify the risk factors, mobilize and exercise patients early to prevent ICU delirium muscle acquired weakness, promote sleep, control the noise, the light, cluster patients' activities. In the daytime, bring up the shades, and nighttime, turn on the shades, have a clock in the room, restart baseline psychiatric medications if required. The A to F bundle is a multi-professional collaborative bundle which entails everybody working together. The nurses, the physicians, the respiratory therapists, the pharmacists, physical therapists, the dietitian, administration support, and even the family and patient. The first part of the bundle is the A, assess, treat, and manage pain. If a reason for pain exists, treat the pain first. Once pain has been addressed, then establish a reason for the use of sedatives. There are various scales that are used: the visual analog, the numeric rating scale, the verbal rating scale, which classifies pain as mild, moderate, or severe. We have the Wong-Baker-Facer scale, so patients who have limited cognitive ability by just observing the expressions. And for patients on the ventilator, the critical care pain observation tool. The second part of the bundle entails coordination and collaboration between the RN, the RT, and the physician. The RN would decrease the sedation or turn it off to perform the spontaneous awakening trial. Then would communicate to the RT regarding the patient's tolerance of the awakening trial. If the patient passes the awakening trial, then the spontaneous breathing trial is started. The patient would be monitored by the RT and the nurse. If the patient passes the breathing trial, then that information will be communicated to the physician, who would decide whether to wean the patient off the ventilator or liberate the patient or consider new therapy goals. Using the SAT and SBT together achieves better patient outcomes. This protocol is a two-step process that includes a safety screen and a trial period. If the patient fails the safety screening, the trial is not initiated that day. Choice of sedation is the third part. It entails the RASS scale, the Richmond Agitation and Sedation Scale. The physician's order should communicate the targeted RASS, which should be -2 to +1, the ideal. When communicating with other healthcare professional about a patient's sedation level, the targeted RASS should be communicated. The actual RASS, the ICU result as positive or negative, and the medications that the patient are currently on, the analgesia and sedative that the patient is currently having. Targeted sedating protocols are effective in achieving sedation goals, minimizing drug accumulation, and maximizing alertness. D in the bundle is for delirium assessment, prevention, and management. We know it affects up to 80% of mechanically ventilated patients. It generates up to 16 billion annually in associated costs in the US alone. It's associated with increased length of stay in the ICU, in the hospital, on the ventilator, increased mortality, long-term neuropsychological deficits. And although varied tools, a great number of tools, up to 45 tools, are available to detect delirium, with 3 of them validated and reliable for detecting delirium in the ICU, it remains undetected and untreated in many patients. E represents early mobility protocols, early exercise and progressive mobility. It is a 2-step process where you have a safety screen and a mobility protocol. The exercises progress from passive exercises, where the provider would provide the exercise for the patient, to active range of motion. It entails sitting the patient in the bed, dangling the feet, assisting them with standing and transfer, and ambulation to prevent ICU-acquired muscle weakness. F in the bundle is for family engagement and empowerment. No care plan is complete without incorporation of the family's wishes, their concerns, questions, and participation. That is why the bundle has evolved to include the letter F for family engagement and empowerment. We know that from a humanistic perspective, this is an appropriate goal of medical care. Empowering family members to be equal participants in care, however, can also lead to several other important outcomes, including enhancing ICU team performance and communication. Identifying patients at risk for developing delirium is the first step in preventing delirium from happening. We can be aware of patients who will experience delirium by educating ourselves about the risk factors and using the validated tools. Therefore, patients should be assessed routinely using a standardized tool to facilitate prompt identification and management of delirium and underlying etiology. There are two tools that we'll be talking about: the Richmond Agitation and Sedation Scale, which detects the degree of sedation or agitation, and the Confusion Assessment Method for the intensive care unit, which assesses for the development and resolution of delirium in the intensive care unit. The RASS is a 10-point scale with 4 levels of escalating agitation, +1 to +4, one level denoting a calm and alert scale, which is 0, and 3 levels of sedation, -3 to -1 to -3, and 2 levels of coma, -4 to -5. It takes only 20 seconds to perform, and it has shown an excellent inter-rater reliability in a broad range of adult medical and surgical ICU patients. So here we have the RASS scale. 0 denotes alert and calm. -1, drowsy. This patient is not fully alert but has sustained awakening to voice, eye opening, and contact for greater than 10 seconds. -2, light sedation. The patient briefly awakens to voice, eye opening, and contact for less than 10 seconds. -3, movement or eye opening to voice but no eye contact. -4 is to touch. No response to voice but movement or eye opening to physical stimulation. -5, no response to either voice or physical stimulation. +1 is restless, anxious, apprehensive, movements not aggressive. +2 is agitated, frequent non-purposeful movements, fights the ventilator. +3, very agitated, pulls to remove tubes or catheters and is aggressive. And +4, combative, violent, immediate danger to self. So the COM ICU can be performed whenever the patient is -3 to +4. Whenever the patient is in a comatose state, -4 to -5, the COM ICU assessment is not performed. The COM ICU is composed of 4 features: acute onset of mental status changes or fluctuating course, inattention, disorganized thinking, and an altered level of consciousness. The patient is considered COM ICU positive and delirious if he or she manifests both features 1 and 2 plus either feature 3 or 4. The COM ICU has been modified and validated and translated in pediatric, emergency department, and neurocritical care populations, as well as over 25 languages. The first step in the COM ICU is to assess the level of consciousness, and that is done using the RASS scale. So step 1 is a sedation assessment, which determines a level of sedation or level of agitation, and that is done using the RASS scale. If the RASS is -4 to -5, the COM ICU is not assessed. It's unable to assess. If the RASS is -3 and above, then the COM ICU is assessed. The second step in the COM ICU entails the assessment for the content of consciousness. Feature 1 will determine whether the patient has had an acute change or fluctuating course of their baseline mental status in the last 24 hours. Feature 2 will assess for attentiveness, and it's usually done using a 10-letter sequence. all attentive patients are alert, but not all alert patients are attentive. So the 10-letter sequence is used in feature 2. Feature 3 is the patient's current RAS level. And feature 4 would be a 4-question and 2-command assessment. So here we have the whole ICU scale. Has the patient had an acute change in their baseline mental status within the last 24 hours? If no, the patient is ICU negative for that first feature. If yes, the patient is ICU positive. For feature 2, we will assess for inattention, and the sequence is 10 letters. You say to the patient, squeeze my hand when I say the letter A. So you read the sequence of 10 letters. We have save a hat, we have Casablanca, and we have a bad day. So we will use save a hat today. If the patient has greater than 2 errors, the patient is ICU positive. If the patient has less than 2 errors, the patient is ICU negative. If the patient is unable to complete the letters, pictures are used. So 5 familiar pictures, and you add 5 more pictures, and you show to the patient in random order. The patient has to say yes to viewing the pictures greater than 2 errors. 2 or greater errors, the patient is ICU positive. The third feature is the patient's current RAS level. So the RAS scale is used twice. It's used for feature 1, where you determine what the patient's RAS was before and whether the patient has had a change. And feature 3, the patient's current RAS level as you are performing the assessment. If the patient is anything other than 0, that patient is ICU positive. Feature 4 is assessing for disorganized thinking. The patient is only allowed 1 error, 0 or no errors. If the patient has more than 1 error, the patient is ICU positive. If the patient has no errors, the patient is ICU negative. So the first question is, will a stone float on water? Yes or no? Are there fish in the sea? Yes or no? Does 1 pound weigh more than 2 pounds? Yes or no? Can you use a hammer to pound a nail? And the commands are hold up this many fingers. You hold up 2 fingers. Now do the same with the other hand. Do not demonstrate for the patient. If the patient is unable to use 1 arm, ask the patient to hold up 2 fingers with 1 hand and then add another finger if the patient is not able to use both hands. The target audience for this intervention today are the nurses in the adult intensive care unit, as they are uniquely poised to be with the patients 24/7. They see the most severely and acutely ill patients. They are frequently performing other assessments so they can detect subtle changes. They are in constant contact with the family, and they are highly trained and skilled professionals. The educational plan, the goal is that nurses in the adult intensive care unit would be able to identify and address risk factors for every patient, that they would integrate patients and families in delirium prevention activities, involve interdisciplinary team members, use a validated screening tool to assess for delirium every shift, integrate in daily rounds the patient's target RAS, the actual RAS, the results of the ICU, and the plan of care for management. With the management of delirium, there is no FDA-approved drug to treat delirium. Haloperidol and atypical antipsychotics are currently being used, but the medication recommended class to treat delirium has little evidence to support treatment. All patients receiving antipsychotics should be routinely monitored for QT prolongation. Always stop and ask, do any medications need to be stopped or lowered? Is the patient on the minimal amount of sedation necessary? Do any titration strategies need to be used, such as a targeted sedation plan or daily sedation cessation? Do the sedative drugs need to be changed? Some of the non-pharmacologic management activities include use clear, concise communication, reorient the patient frequently, visual reminders like clocks and calendars, don on their hearing aids, put on their glasses, put the names of the care team members on the board, offer them the newspaper, put on the TV, talk to them about the news, discuss the schedule of activities and the plan of care. Offer them cognitive stimulating activities, put the shades up in the daytime, down in the nighttime, control excess noise and light, provide familiar objects, allow it in those from home, by the bedside, and ambulate and mobilize early and often. Okay, let's go to the features again for the CAM ICU. The first feature, feature 1, what you are determining is whether the patient has had an acute change or fluctuating course of mental status. Has the patient's baseline mental status changed during the last 24 hours? If yes, the patient is CAM ICU positive. If no, the patient is CAM ICU negative. Feature 2, check for inattention. You say to the patient, squeeze my hand when I say the letter A. Use the 10-letter sequence, Casablanca, a bad day, and save a hat. So you use any one of those 10-letter sequence. The patient has to recall a sequence of 5 or 10 pictures if the patient is not able to hear. 0 to 2 errors means the patient is CAM ICU negative. Greater than 2 errors, the patient is CAM ICU positive. Feature 3 is the patient's current RAS level. So you use the RAS scale to determine where the patient is on that scale. If the patient is anything apart from 0 on that scale, the patient is CAM ICU positive. And then feature 4 is an assessment for disorganized thinking. So you use these 4 questions. 1, will a stone float on water? Are there fish in the sea? Does 1 pound weigh more than 2 pounds? Can you use a hammer to pound a nail? And the 2 commands, you ask the patient to hold up 2 fingers and do the same with the other hand. And if the patient is unable to use both hands, then you ask them to add 1 more finger with the 2 fingers on the good hand. Okay, now for the practice using real case scenarios. Here we have a case. Miss G is a 65-year-old admitted for acute respiratory failure. She lives independently in her own home, is active in church, and drives herself everywhere. You walk into the room and she looks at you immediately. She appears anxious and she's being ventilated with BiPAP. Her arms are restrained and she's pulling at them to get her BiPAP mask off. Step 1, has Miss G had an acute change in her baseline mental status within the last 24 hours? She's currently at a +2. So she's had her baseline mental status change. Originally, she was an awake, alert patient. She was independent, driving herself, going to church, and doing everything for herself. So her baseline mental status was at a RAS of 0. But now she's a +2. So she's positive for feature 1. Feature 2, she made 5 errors on the letter test. You are only allowed 0 to 2 errors. Anything greater than 2, you're positive. So she is positive for feature 2 on the letter test. Her current RAS is a +2, so she is positive. And step 4, she answers 2 questions correctly and completes the full command. She is CAM ICU positive because she does have feature 1, 2, 3, and 4 positive. Scenario 2. TJ is an 80-year-old patient who was successfully weaned from the ventilator and extubated at 8 o'clock after abdominal surgery. He is alert and calm since all sedatives and analgesic medications have been stopped earlier in the morning. Yesterday evening and last night, he had been having periods of agitation with a documented RAS of -1 to +3. He lives with family due to physical limitations with mobility, but is still cognitively intact. He correctly answered all the questions and performs the commands. He squeezes correctly on all the letters. Is he positive or negative? Step 1. TJ is assessed to be a -1 to +3, so he is positive for that feature, the feature 1, because it's an acute change from his baseline mental status. He made 0 errors on the letter test, so he's negative for inattention, and his current RAS is at a 0, so he's negative. He answers all questions correctly and completes the full command. So for features 2, 3, and 4, he's negative, so he is a COME ICU negative. Third case scenario, you enter the room of Katie, 78-year-old cardiac patient you have been seeing over several days. She lives at home and cares for her husband. She has been -1 to 0 and COME ICU negative for the past 24 hours. She is RAS 0 this morning and greets you by saying, "How do you think I look?" You exchange pleasantries about how she's doing today. She answers 2 questions correctly, completes the full command, and makes 4 errors with the letter test and 5 errors with the picture test. Is she COME ICU positive or negative? For feature 1, she is assessed to be -1 to 0, which is a change from her baseline. She's 0, so she's positive. She made 4 errors on the letter test. She's positive. Her current RAS is 0. She's negative, but she answers 2 questions correctly and completes the full commands. She is COME ICU positive. Fourth case scenario, you enter the room of a 65-year-old BJ admitted 2 days ago after she had emergency abdominal surgery. She's still on the ventilator, her eyes are closed. She does not open her eyes to verbal stimuli, but does respond to physical stimuli. She was on paralytics and has been off them for 24 hours. She's still receiving sedatives. She has been RAS -5 to -2 over the past 24 hours. She's unable to follow any commands. Prior to surgery, she had just retired from her teaching job. Is she COME ICU positive or negative? BJ is assessed to be a -2 to -5 for the past 24 hours, so she's positive for feature 1. For step 2, she is unable to perform the attentive test. And step 3, she is at a current RAS of -4. Step 4 is unable to assess, so this patient is unable to assess because of her degree of coma. Case scenario 5. You have been caring for TP, a 22-year-old male in PACU. He was in an MVA and went into the OR for internal fixation for a left ORIF. He is now 30 minutes into his recovery period and slowly begins moving and moaning. His movements are not aggressive. When you speak to him, he opens his eyes briefly, makes eye contact for 2 to 3 seconds before closing them again. He was awake and alert prior to going to the OR. He makes 3 errors on the letter test. Is this patient COME ICU positive or negative? For step 1, feature 1, TP is assessed to be a RAS -2, which is an acute change from his baseline of 0, which is awake alert. So he is positive for feature 1. In step 2, feature 2, he makes 3 errors on the letter test, so he's positive. And his current RAS level is a -2 for feature 3, so he is positive. Step 4 is not assessed because it's not necessary. All you require is an assessment, a positive assessment in 1, 2, and either 3 or 4. So TP is positive for COME ICU. What is the significance of delirium assessment to healthcare? Delirium is a common clinical event in adult intensive care unit patients, and it's associated with significantly longer time on mechanical ventilator, increased length of stay in the ICU, increased length of stay in the hospital, higher ICU and healthcare costs, prolonged and permanent cognitive defects after discharge, increased residential admissions. Positively, early detection has helped to increase safety, improve quality of care, reduce morbidity and mortality, and reduce costs to the healthcare system. Dissemination of the information on the assessment, prevention, and management of delirium activities in the intensive care unit. The goal is that adult intensive care unit nurses would acquire knowledge on the application of the RAS and CAM ICU. They would gain comfort using the RAS and CAM ICU, and they would perceive delirium assessment, prevention, and management as part of their routine activities. Now, let me inform you about the significance of the project and its impact on healthcare delivery, outcomes, practice, and policy. For healthcare delivery, healthcare providers should aim to improve patients' lives, which fulfills one of the ethical principles of beneficence. Adult ICU nurses should ensure that they are on the alert to spot delirium. They should provide the highest quality of care for ICU patients using evidence-based practice guidelines and standards of practice. Adopt a culture of safety to reduce functional decline and demise. And additionally, this project will serve to remind providers of the analgo sedation guideline, which says that you treat a patient's pain first before sedating a patient. For the significance of the project and impact on healthcare outcomes, the outcomes that we are looking for is a reduction in ICU stay, a reduction in hospital stay, reduction of time on the vent, reduction of ICU acquired muscle weakness, reduction in healthcare costs, morbidity, mortality, and long-term cognitive dysfunction. So here we have the implementation of the A to F bundle that I talked about earlier. So we have to ensure that we are adopting those practices because it's part of the Society of Critical Care Medicine guidelines for standards of practice in the ICU. For the significance of the project and impact on practice, the idea is that nurses will be able to articulate delirium signs in practice. They would adopt the practices outlined by the Society of Critical Care Medicine for the assessment, prevention, and management. They would use validated instruments to screen for delirium at least once a shift and take proactive approaches in assessment, prevention, and management. So the non-pharmacological interventions are the ones that are recommended and involve interdisciplinary team members also. For the significance of project and impact on healthcare policy, the stakeholders, so the care managers, the department and unit managers, are required to work in concert with the staff to facilitate change. The goal is that a policy will be adopted in concert with the 2018 guidelines for the management of delirium in the adult ICU to screen for delirium using a validated screening tool and adopt the recommendations as outlined by the SCCM for delirium assessment, prevention, and management. Remember, there is no FDA-approved drug for delirium, so we have to use non-pharmacological approaches. We have to take care of a patient's pain before we sedate a patient. All of those interventions, including identifying their risk factors to help in delirium prevention. With staff education and support, the use of delirium champions, like those who already know how to use the scales efficiently, can train other colleagues. The guidelines or care bundles can be implemented, like multidisciplinary round forms, which have been in use at some facilities, so this can be emulated at other facilities. What is the significance of the project on the DNP Essentials? For DNP Essential, which talks about nursing science and theory, scientific underpinnings of practice. Nursing is a discipline. The practice of nursing is a performance art. Essential 1 is reflected in acquiring the knowledge on delirium, taking that knowledge to improve a patient's circumstance. Application of new knowledge on delirium, assessment, prevention, and management is the fulfillment of the first essential. Essential 2 has to do with healthcare organizations and systems leadership for systems improvement and systems thinking. This essential requires improvement in practice that is in concert with the unit and healthcare organization support. The healthcare organization should be led to appreciate the cost effectiveness that this change in culture would reproduce. This project on delirium prevention would decrease costs, length of stay, hence improving quality of care and decreasing costs and improving patients' outcome. Essential 3, the significance of the project on DNP. Essential 3, clinical scholarship and evidence-based practice. This is reflective in the literature review and appraisal of the research on delirium in the adult ICU from the commencement of the project to the dissemination of findings today. An educational intervention is being delivered to spotlight delirium in the adult ICU and to call for action in adult ICU units for delirium assessment, prevention, and management. DNP Essential 4, the significance of the project. It deals with information systems, technology, patient care technology for the improvement and transformation of healthcare. Dissemination of the research project through the medium of a video presentation and posting on a global network, YouTube, will facilitate broadcasting of the research globally for knowledge and for further research and clarification and correction and edification. The significance of the project on DNP Essential 5, healthcare policy for advocacy in healthcare. My current place of employment has embraced the research on delirium prevention activities and use of validated tools for screening for delirium through their online documentation and interdisciplinary rounds. Additionally, a policy exists for daily sedation vacation and current online documentation for the RAS and CAM ICU. The goal is that this could be implemented at multiple facilities around Florida to improve patient health outcomes. What is the significance of the project on DNP Essential 6? Interprofessional collaboration for improving patient and population health outcomes. The A to F bundle, as recommended by the Society of Critical Care Medicine, necessitates an interdisciplinary approach with the care of the ICU patient. Every member of the team, the intensivist, the nurse, the RT, the dietitian, physical and occupational therapist, lab technician, family members, everybody is required for the implementation of the bundle and to improve patients' health care outcomes. For DNP Essential 7, clinical prevention and population health for improving the patient's health. Central to this scholarly project, as delirium is a syndrome that proactive approaches can be employed to prevent. Providing knowledge to ICU nurses and sharpening their skills will equip them to be able to identify risk factors, detect precipitating factors for delirium promptly, and adopt evidence-based practice guidelines. Utilize reliable and validated tools to prevent increasing healthcare costs so patients can achieve better health. The incorporation of the RAS and CAM in routine assessment will serve as an objective tool to communicate to the interdisciplinary team regarding patient status to seek corrective causes. The final essential, DNP Essential 8, Advanced Nursing Practice. The DNP scholar implemented all of the 8 DNP essentials to advance nursing practice and the nursing profession. This scholarly project is to implement an educational intervention for critical care nurses in the adult ICU on delirium using evidence-based screening tools, the CAM ICU, and the RAS. Currently, I serve as a mentor and provide education using RAS and CAM ICU. Additionally, completion of this project will fulfill the requirement for this essential as evidence-based practice guidelines provided by the SCCM will be used as a standard of practice to improve patient outcomes and advance nursing practice. What about COVID-19, the pandemic, and my project implementation? I was officially approved by the Barry University to implement my scholarly project at a South Florida hospital, but due to COVID-19 and the requirement for social distancing, I was unable to implement the project at that facility, resulting to dissemination via a YouTube video. I anticipate that I have provided you with valuable information for use in your practice in the adult ICU. My plans regarding the delirium issue. My goal is that I can disseminate the research again at my current place of practice, as my director has asked that I teach the new staff about the RAS and CAM ICU. Additionally, I would like to disseminate this project at my initial approval site when the COVID-19 has cleared up. At my future place of employment, I would like to disseminate this research and also other research to improve patient health outcomes and decrease costs in healthcare. I would like to do a presentation at a DNP colloquium, have my poster presented, and also to present at a local ARNP chapter meeting. Thank you for your patience and for viewing my audio-visual presentation.